Okay, so now we'll be covering antivirals and antifungals. And this one is a bit of a mouthful, but just bear with me. So, pretty much what you just need to know with these is you need to know whether it's a fungal infection, whether it's a malarial or a protozoa infection, whether it's anticestodal, etc., etc. So you need to know what type of microorganism is causing the infection and where is it, and as a result that will determine the type of treatment that you're going to be having. So the first thing that we're going to be starting with is our fungal skin infections. These are known as our dermatophytes or tinea or ringworms. These grow and proliferate in non-living stratum corneum layer of the keratized tissue of the epidermis. So they pretty much grow on the top layer of your skin. So there's obviously different types of tinea or dermatophytes or ringworms. So please note that all those names might be used, but it's all referring to the same thing. So tinea capitis, this is infection of the head. It causes round patchy bald areas, and how we treat this one is we use fluconazole, which is 200 milligrams once daily for 28 days. Or if it's for younger kids, usually those under 12, they'll say 6 milligrams per kilogram. So obviously if the child is 6 kilograms, then you times it by 6 milligrams, the child will get 36 milligrams. Okay, and then we've got tinea corporis. This is on the major skin surfaces except your face, hands, feet, groin, and scalp. So it's anywhere else like your neck, your stomach, etc. Treatment would be using clotrimazole 1% cream 3 times a day for 2 weeks post lesion. So you must use it for 3 times a day until the bald patches or the lesions on the skin have disappeared, and you must continue for 2 weeks after they've disappeared. Or you can use griseofulvin, but this is a systemic one, meaning it's either you're gonna take it orally or it's gonna be given IV, and this would be for extensive skin, hair, and nail infections. You would take it so the oral one, you take it with or after a fatty meal or after drinking milk, and it's taken once daily. And how it works is pretty much it inhibits cell division of the fungus, and as a result, if the fungus is not able to divide, it's not able to spread and cause more infections. Then we've got tinea vesicolor. This is skin infection, but it is caused by a yeast. Treatment would be selenium sulfide shampoo or Selsun. You use it for 3 days, so you leave it for 3 minutes and then you wash it off, and then you do the same thing for the next 2 days. And then we've got tinea pedis. This is obviously, pedis is your feet, so this is a fungal infection of your feet. So treatment is you need to make sure that you're drying the skin thoroughly, especially between the toes. You need to wear cotton socks because they allow for circulation of air, so that there's no moisture. And then you need to make sure that you're wearing dry socks. So socks especially that you dry outside, you need to make sure that they're completely dry and they don't have any dampness to them. You need to avoid constantly wearing closed shoes. So if you're in the house, rather either walk barefoot or shoes that do not have any, like slippers, etc., etc. And then you can put antifungal powders in the shoes and your socks to treat this infection. And then please make sure that you're wearing flip-flops in public areas, especially if you're going to the gym or to the park or to the beach. And then treatment would also be clotrimazole, but this one is a 2% cream and is used twice daily for 4 weeks. And then, so please note that when it's tinea pedis, the concentration of the clotrimazole, it's a bit stronger, so it's 2%, while the one that you use on your head or your major skin surfaces actually, is 1%. So different areas might require different strength of medication. Then we've got tinea crucis. This is the rash that is in your groin area, in the inner thigh, and it can even spread to the buttocks. So there's different treatments that you can use. So you can use terbinafine, or also known as Lamisil. That is a cream that is used once or twice per day. Or you can use an emulsion gel. So emulsion gel is when you cover your whole body once daily for 7 days. So you can use the cream that you use once or twice daily, you apply it, or you can use the emulsion gel where you cover your whole body from your neck downwards, and you use it once a day. You wash it off for 7 days. This one, it's got high cure rate, so that means it's very effective, but unfortunately it's very expensive, so it's not really prescribed in public hospitals, and you mostly find it in a private practice, etc. Then another one that you can use is benzoic acid and salicylic acid, also known as Whitefield's ointment. This one is used 2 to 3 times per day. It's got a slower resolution of symptoms, so it takes a longer time, and as a result it's got a less cure rate, but it is more cost effective. And then you've got tonaftate or tinidem. This is used twice daily for 7 days, even after the symptoms have cleared, so 7 days post lesions. And then you've got andesinoates or mycota. This is used twice or bi-daily for 7 days after the infection has cleared. So as you can see, with most of these, you still have to continue using it even if the infection has disappeared. Use it for a few more days, usually for 7 or up to 2 weeks after the lesions have gone, because even though you might not have symptoms and there's no lesions, the infection might still be there. So use it for a bit more time to make sure that the fungal infection is completely destroyed. Then we've got topical imidazoles. This is good, and it's got a good safety record, but the side effect is that it might cause some irritation on the side. And then if you've had a previous hypersensitivity, please do not use this. So example of your topical imidazoles is chlorotrimazole 2%, also known as cane stain, as we've already mentioned, using it in tinea pedis and corporis. And then we've got ketoconazole. So as you can see, your topical imidazoles, all of them end in zole. So your ketoconazole, it's used once daily or twice daily until 2 to 3 days post signs and symptoms. And then you've got your miconazoles, which is used twice per day until 10 days post lesions. So those were your fungal skin infections. So now we're going to our nail infections. So these are known as your onychomycosis. This is obviously an infection of the finger or your toenails caused by Trichophyton rubrum and Trichophyton interdigitale. Treatment is nail removal may be necessary, but obviously that would be the last thing that you'd want to do. It's a systematic treatment. You require systematic treatment if more than 2 nails are infected, and then a nail paint is used short term. And then obviously if that does not work, they'll use systematic treatment where you take it orally. And then if that does not work, then obviously they have to remove the nail. So the first one is your amorolfine or Loceral 5% nail liquid. So it's the nail paint. You apply it weekly until the nail has regrown and is clear of infection. This might take about 9 to 12 months. Or you can use griseofulvin. But obviously we say this is for severe infections and it's taken orally. Next, we have Candida. This is an infection of the mucous membrane of your vagina, mouth, or skin. So if you have oral candidiasis, or also known as thrush, this is mostly common in patients with HIV or TB. This is a painful creamy white patches on the tongue that can be scraped off. It's extremely painful, especially when they are eating. So treatment would be using nystatin suspension orally, which is 100,000 units per milliliter 6 hourly after a meal for 7 days. So pretty much you take the solution, you swirl it in your mouth so that it's in contact with the mucous membranes for as long as possible, but please do not swallow, and then you spit it out and you continue for 7 days. After the lesions have obviously been removed, then you must continue for 2 more days to just make sure that it's completely destroyed and it's pregnancy safe. And sometimes even babies are given this, but obviously in a very controlled environment. Then we've got systemic fungal infections. So these are infections that are mostly inner, I guess I can put it in that way. Examples would be your oropharyngeal candidiasis, which is pretty much your throat area. Then cryptococcal meningitis, pulmonary aspergillosis. This is usually after a bone marrow transplant, etc., etc. So it's things that are not on the outside. Treatment would be, example would be Candida esophagitis. This is a pain or difficulty in swallowing. Treatment, obviously maintain hydration, and they'll be given fluconazole 200 milligrams per oz once daily for 14 days. Okay, so there's really 2 main types of treatments that they use for systemic infections, which is your fluconazole and amphotericin B. These ones you really have to know about. So fluconazole is obviously used for candidiasis and cryptococcal meningitis, and the distribution is wide, meaning it can enter your CSF. It's excreted unchanged in the urine, and you need to watch out for drug interactions with rifampicin, so patients that are on TB treatment, because it can cause some renal issues if it's combined with rifampicin. Side effects include GI, so that's your stomach cramps, diarrhea, etc., dyspepsia, abdominal pain, headache, skin rash, etc. And then amphotericin B, this is used for severe systemic mycosis. It's given IV, but the adverse effect is that it causes nephrotoxicity, so you need to watch out when you're using it with your aminoglycoside antibiotics. And it also causes hypokalemia, which is a decrease in your calcium level, so you need to watch out when you're using it with your diuretics. And as a result, toxic monitoring is very important for both fluconazole and amphotericin B. Side effects of amphotericin B is fever, chills, headache, nausea, vomiting, and malaria. Okay, so next is your antiprotozoas, and the main one that we're going to be dealing with is malaria. But obviously there's different types. So with malaria, the infective microorganism is Plasmodium spp. It causes flu-like symptoms that tend to appear in cycles. And then we've got amoebiasis. And then the type of microorganism is Entamoeba histolytica. This is a parasite that affects your liver or your intestine. And then you've got your trichomoniasis or T. vaginalis. This is obviously an STI which infects the vaginal or the lower urinary tract. Treatment would be metronidazole. And then we've got our giardiasis or G. labiata. This is asymptomatic. So when you get infected with this, you might not necessarily see the effects, but it presents with diarrhea, flatulence, which is farting, and intolerance to milk products. And then if you get infected with Bilharzia or Schistosoma spp, it occurs when you are swimming in infested water, and the treatment would be praziquantel. But you will see all these medications when we're speaking about malaria treatment. So there's something that is known as the ABCDE of malaria, and they all stand for different things. So the first, and this all counts for the treatment of malaria. So A stands for awareness. So should you be traveling to an infested area with malaria, you need to know what's your risk of getting infected, and this is dependent on the area that you're visiting, the time of year, the altitude, the number of bites that are usually present in that area, etc., etc. Because obviously, if there's a higher risk of you getting malaria in that area, you'd want to avoid going there. And then the next thing is bite prevention. Obviously, you try to avoid visiting malaria infested areas in the dry season because mosquitoes are more prevalent in wet areas. And then you need to wear light colored, loose fitting, long sleeved clothes and use mosquito nets and insect repellents, etc., etc., keeping your doors and your windows closed. Cool. Example of these insect repellents would be pyrethroid insecticide, or known as Peripal. This is 20 to 50%. It contains 20 to 50% NN-diethyl M toluamide. Don't really worry about the details. It's also known as DEET. And then we've got chemoprophylaxis, which is C. So chemoprophylaxis is pretty much when you're giving medication before you have the illness, and it's given on the basis on the risk versus benefit. So some patients they'll rather give you because you're highly likely to get malaria because of your age or medical conditions that you have versus the risks that you might have. So not everyone might get prophylaxis, but it's highly advisable that you do. And it depends on the resistance that is in that area, because some areas in the world they have more areas that are resistant to certain anti-malarial medication. So obviously they need to make sure that they're giving you a medication that will work in the area that you're going in. And then also depends on the intensity of transmission. So if you've got areas that are highly prevalent with malaria, they have to give you a strong dose of chemoprophylaxis. And then also depends on your age and medical history. But chemoprophylaxis is contraindicated in pregnant women and those younger than 5 or older than 60. So obviously pregnant women, those younger than 5 or older than 60 should avoid going to areas with malaria. So when it comes to chemoprophylaxis, there's 4 different types of prophylaxis that they can give you. I'm just going to open this part. Okay, so before I go to the chemoprophylaxis, there's few things that you need to note. So there's what is known as your pregnancy categories of medication. So it goes from category A, B, C, D, and X. So category X means that studies in animals or humans have demonstrated fetal abnormalities, or there's positive evidence of human fetal risk. So when a medication is being put out, they need to test it on animals and then test it on humans to make sure that it's safe. And then especially now when they're dealing with pregnant women, they need to test animals that are pregnant and women that are pregnant and see what is the effect of that drug. So if it's category X, it means that the drug is harmful to both human and animal fetus, therefore it cannot be given to anyone. Then category D, it means there is a positive evidence of human fetal risk based on the adverse reactions that they have found in animals, but there might be potential benefits, so they might consider giving it to a pregnant woman. Then category C is that animal reproduction studies have shown adverse effects on the fetus, and there are no adequate or well-controlled studies in humans, but obviously the potential benefits outweigh the risks. And then category B is when animal reproduction studies have failed to demonstrate a risk on the fetus, but there hasn't been any study done on humans, so they can still give it because in animal reproduction the fetus wasn't affected. And then in category A, it shows that both in animals and humans it was tested and it was safe, and therefore they can give it. So when we come to our chemoprophylaxis, the first one is mefloquine. This one is a drug of choice for pregnant women, for those that really do want to travel but would rather contraindicate that they don't. But should they be wanting to travel, they would be given, they would know that mefloquine is a category B, meaning it's been tested on animals and there's no risk on the fetus, but it hasn't been done in pregnant women that are obviously human, so it's still somewhat safe. So please note that these things are going to be thrown around about pregnancy category, what, just to for you to know that what has it been tested on. Anyway, so mefloquine, this is recommended in chloroquine resistant areas. So as I mentioned, there's some areas that certain antiprotozoals have developed a resistance because it's been overused. So there's certain areas in the world where chloroquine, which is another chemoprophylaxis that we're gonna cover, it doesn't work in that area, so they'd rather give you mefloquine. So that is a tablet that is swallowed whole with plenty of fluids, so not just a small little cup. You need to give lots of water with it. An example would be larium or meflium, and this is taken 1 to 2 weeks before you have to travel, and 4 weeks after you've come back, and it's taken once weekly. It's contraindicated in anyone with mental issues, liver or kidney impairment, and then if you've any heart conduction issues, and for any children that are less than 5 kilograms, you cannot give it to them. Side effects include neuropsychiatric issues, dizziness, vertigo, GI effects, headache, visual disturbance, and chest pain. And then we've got doxycycline. This is a very famous one. It's recommended for non-pregnant women and children older than 8 years, and it must be used short-term in multi-drug resistant areas. So areas that are more resistant to the other chemoprophylaxis, they would mostly use doxycycline. But it's contraindicated in anyone who's pregnant or younger than 8 years. So when you're giving the medication, you must give it with adequate fluid, so not just a small sip, but lots of water in an upright position. You must take it before sleep, and the dosage is 100 milligrams once daily after a meal. It must be taken 1 to 2 days before the trip and 4 weeks after. Please note that with all these chemoprophylaxis, you have to know how many days or weeks before the trip and how many days or weeks after the trip do you have to take these medications. Then we're gonna go to atovaquone proguanil. You must take it with food or milk the same time each day, and it's taken 1 to 2 days before the trip and 7 days after the trip. An example of this is Melanol. Side effects include gastric intolerance, mouth ulcers, and stomatitis. Drug interaction is any medication that causes hepatic impairment. So most antibiotics, you need to watch out for drug interactions because it can cause liver failure. And then it's contraindicated with anyone with kidney or liver impairment, any pregnant woman, and kids less than 11 kilograms. And then the last one is chloroquine. This is limited to areas where P. falciparum, which is the microorganism that causes malaria, is not resistant in. So if any, because most areas are actually now very much resistant. I mean, this microorganism has become very resistant to most of these chemoprophylaxis. So chloroquine is rather used to areas where this organism is not there, or it's not resistant to most drugs. And you must take it with food, as with all of them, once daily. You must take it 1 week before you travel and 4 weeks after. So please take note of how many days before and how many days after you come back. Cool. So the ABCD of malaria, we've covered awareness, bite prevention, chemoprophylaxis. Now we're coming to D, which is diagnosis. So diagnosis, symptoms include chills, nausea, vomiting, headache, fever, and sweating. So you will have the symptoms for several days, and then it goes away, and then it comes back 2 to 3 days after, and they can occur every 3 months to 1 year after returning. So even 12 months after you've come back, you might have these symptoms come and go. And then severe symptoms would be a dry cough. So obviously, when a patient has, that's why history taking is very important with such patients, because if someone has chills, nausea, vomiting, headache, fever, and sweating, you would think of many other things that are not malaria. So obviously, if someone tells you that they travel to an area where there's malaria, then you need to start thinking perhaps they might have this, and then blood tests will start happening, etc. And then E would be treatment. I don't know why it's E and it's T, but anyway, so if it's uncomplicated malaria, you'd be given artemisinin. This is a combination therapy, combination of artemether and lumefantrine. And then if it's severe malaria, you'd be given artesunate and quinine, and this is given IV. So the combination artemether and lumefantrine is only for uncomplicated malaria, and you've got a normal mental state. That means you have no side effects. There's adequate urine output, so that means your kidney fail, you don't have any kidney failure or kidney damage. And if there must be non-vomiting, it's administered with fatty milk or milk, and then improvement occurs within 48 hours, and you must complete 6 doses over 3 to 5 days. But drug interactions include hepatic enzyme inducers, so any medication that have anything to do or that affect your liver, you must watch out for these drug interactions because they can lead to liver failure. And then any drugs that have to do with your heart, so your antiarrhythmic medication, you need to watch out for drug interactions because they can cause issues. So contraindications: if you are hypertensive, you've got a history of QT prolongation, or you've got low levels of potassium and magnesium, you need to not give it to these patients. Okay. And then quinine, it causes it's metabolized in the liver or hepatic metabolism. Therefore, any medication that it interacts with that deals with the liver, you need to watch out for drug interactions. And then you know that it's reached a toxic level if your serum levels in your liver are more than 20 micrograms per milliliter. But you guys don't really have to know this, because this would happen with your doctor, and your doctor would be more concerned about it. But anyway, it's contraindicated with anyone who's hypertensive, have tetanus, optic neuritis, hemolysis, or any history of low platelet levels. And then drug interactions, anything that has to do with the liver, you need to watch out for drug interactions. And if anyone is taking antacids or urine alkalinizers, you need to watch out for those drug interactions because it can cause liver and kidney issues. Adverse effects is it can cause tetanus, impaired hearing, headache, nausea, blurred vision, giddiness, etc., etc. Loading dose is very critical. It must be given in a controlled infusion over 4 hours so that you can watch out for cardiac toxicity. You need to monitor your blood glucose, and it's given IV and not IMI because IMI causes necrosis of your muscle. Next, we have our ectoparasites, pediculosis. This is infections of the feet. Treatment would be using a lotion, a liquid, or a mouth shampoo. You dilute it with water, and you make sure that the contact time between the medication and the body part is for as long as possible. And my bad, pediculosis is your hair and not your feet. And then you must use the liquid for kids that are younger than 12, and those that are asthmatic, because it can cause some issues. And then if the lice is in the eyelash, you need to remove it manually using a small comb, and then apply a petrolatum. It's pretty much like what do you call it, eye mascara, and you just apply it on your eyelashes. And then should it not resolve, then you can shave the head. And then, so treatments that you can use for the hair, you've got permethrin or EDL, or likely a 1% cream rinse. So you towel dry your hair, so you wash it and then you towel dry it, and then you put the solution, you leave it for 10 minutes, and then you rinse your hair, and then you continue that every single day. And then we've got dimethicone 4% lotion. You apply it to dry hair, and then from the scalp to the tip of the hair, you make sure that you cover it, and then you can leave it for 8 hours. So you put a shower cap on top, you sleep, and wash it the next day. And then another ectoparasite is scabies. So scabies, they've got a 14-day cycle. So obviously you need to make sure that you're treating them for longer than 14 days to make sure that it's completely killed. So treatment is itching after treatment, and this is usually okay 2 to 3 weeks then on. So pretty much what the itching is caused by is the saliva of the microorganism. That's what causes the itching, and it can still be there 2 to 3 weeks after the treatment. Okay, so you need to wash your clothes, linen, at a high temperature and dry it in the sun. You must make sure you don't have any long nails, and don't apply the treatment after a hot bath, because there's possible systemic absorption, and should that happen, it will cause some serious side effects. And if anyone in the family has scabies, you need to treat the whole family with monosulfuram or tetmosol soap, and you need to do this once and then repeat it after 7 days. And then another treatment that you can use is benzoate EDL 25% solution. You apply it from the head to the neck over 2 consecutive days. You leave it overnight, and then you wash off the next day, and this can be used in adults and children. Another treatment that you can use is sulfur 5% ointment. So as you can see, it went from 25% to 5%. So they all have different concentrations depending on how long you're gonna use them for. So the 5% ointment, you use it for 3 days in children older than 6 years. Okay, and then you've got your anthelmintics. These are your worms. This you start getting from the age of 6 months, and then you do it every you start from 12 months, and then you give it every 6 months. And you'll see this in the clinic when you go get your immunizations. They will start giving it to you every 6 months with your vitamin A supplementation. Symptoms include perianal itching, anemia, failure to thrive in kids, etc. And how you diagnose that the child has worms is if you see any worms in the stool. Okay, and then we've got our AntiNemaToda, or your roundworms. The treatment, you use mebendazole, albendazole, and your piperazine. So your mebendazole, this is a broad spectrum antinematoda agent. It's used in children that are 1 to 2 years old. They're given 100 milligrams twice daily for 3 days. If you're over 2 years, then you're given 500 milligrams single dose. And then please note, with all of these, you need to know the mechanism of action of these drugs. So mebendazole, it inhibits the glucose uptake of the roundworm, and as a result, it's not able to grow because it does not have glucose, and as a result, it dies. You pretty much starve it, while piperazine will paralyze the worm. Anyway, so mebendazole, you can give Vermox tablets and also a suspension. Suspension is any liquid that you keep in your mouth for a while and then you spit out. You must make sure that you give it. If it's a tablet, you give it with the 30 ml because it increases the absorption, and you need to avoid it in the first trimester of pregnancy. And then piperazine, this is for roundworms or a pin threadworm infestations. If it's a roundworm, you need to give it a stead dose, that means immediately. And then if it's a pin or a threadworm infestation, you need to give it for 7 days. It can either be mixed with water or milk. Example would be piperine syrup or Pedix granules. And syrup you need to avoid in the first trimester and in pediatrics or kids younger than 3 months. If they are constipated, you'd want to give a purgative or a laxative first, and then give the piperazine, and then you can give the second dose 24 hours later to just improve the efficacy of the treatment. And then we've got our anticestodal agents. So this is treating your tapeworms. Example of medications would be niclosamide, praziquantel, albendazole, and mebendazole. So treatment considerations, you need to make sure that there's good hygiene, you're treating the whole family, you're checking the stools for any worms, and you repeat the dose 14 days later if necessary. So when using niclosamide, it inhibits the metabolic processes of the worm. Absorption is about 10 to 20% in the stomach, and it's excreted unchanged in the feces. Treatment can occur in the second and third trimester in kids older than 2 years. If constipated, you first give the purgative the night before the treatment and you give it the next day. And an antiemetic or anti-vomiting medication may be given because it does cause nausea, and you need to avoid alcohol. Oh, excuse me. And then if you have a pork tapeworm, you need to give a second dose of purgative 2 hours after the dosage. And this is just to cause the bacteria to pass out of your body. And then you've got praziquantel. 80% of the dose is eliminated in your urine. Adverse effects include drowsiness, and therefore tablets should be taken and chewed with water after a meal. So these are all your antimicrobials. If you have any questions, write them down or email them to me and I will answer them. And then on Tuesday, I will let you know the time we can have an hour session to answer all the questions. Thank you.